This episode of AHLA's annual Top 10 series, discussing the major health law trends and developments of 2026, is sponsored by StoneTurn. Learn more at stoneturn.com.
Welcome to AHLA's Top 10 podcast series for May 2026. My name is Okem Wogu. I'm a managing director at StoneTurn, a global professional service firm that works with law firms, corporations, and government agencies in solving some of the most complex and consequential business issues. I'm in a disputes and economics consulting group where I provide analytical and strategic insights on litigation and management consultant experiences and matters. I'm joined today by Megha Mathur, an associate at Barnes and Thornburg. Megha is one of the authors of Health Law Connections article we'll be diving in today. Megha, thanks for joining me.
Sure. Okay, thanks for having me, and thanks to the AHLA for hosting this great series. Like Okem said, my name is Megha Mathur. I am an associate at Barnes and Thornburg in our healthcare department in the Chicago office. My background is mainly in public health, so I tend to take that lens on most of the work that I do. But my sort of bread and butter is white collar healthcare litigation. So audits, compliance, investigations, all that good stuff, mainly focusing on the False Claims Act, the Anti-Kickback Statute, and Stark Law.
Well, healthcare has driven the largest share of False Claim Act recoveries for more than 20 years. What's changed recently isn't just dollars, it's scale. Enforcement actions now span dozens of districts, hundreds of defendants, and entire networks of providers, vendors, and platforms. From a data perspective, we're seeing fewer isolated outliers and more interconnected systems coming under scrutiny. With that context, let's dive in. So, Megha, healthcare fraud enforcement has always been active, but increasingly it feels defined by scale rather than volume. What does that shift look like in practice, and why does it matter for organizations trying to manage risk?
Sure. And that's a great first question because it touches on, I think, almost every trend that we expect to see in 2026. But just stepping back for a second, I think historically, a lot of healthcare fraud enforcement was about lots of individual cases. So, physician group here, a lab there, a hospital here, lots of small fires. What's changing now is that the DOJ is going after an entire business ecosystem at once. And so instead of just investigating a single doctor, they are investigating the telehealth platform that maybe fed the doctor, the marketing company that might have found the patients, maybe if there was a DME supplier that shipped the product, if they had a billing company that submitted claims, and these days, maybe even if there was a private equity owner that financed that physician. So when we talk about scale, that's really what that means in practice. It's not just looking at one provider who might have behaved poorly. It's whether there was an entire commercial system designed to manufacture claims. And the reason that we're able to see these systems now is data. And so the government can now see patterns across millions of claims. And so they can see how quickly patients were acquired, how often the same codes appear, whether a small group of physicians, a small portion of them account for really large volumes, or even whether the referral paths even make clinical sense. So instead of waiting for a whistleblower for that small fire when they call and say, hey, something looks a little funny, the DOJ can identify outlier behavior on its own and then reverse engineer the system behind it. So for organizations in the healthcare space in 2026, the risk is not just your own conduct anymore, it's whether you sit in a system that looks a little risky. So you might just be that individual provider or that individual vendor or whatever. But if you sit inside a system, the DOJ is going to evaluate you as part of that system. So even if you acted in good faith, it's that system that's causing the risk. So to to the extent the question is about risk management, it's less about did we violate a rule and more do we sit inside a system that creates risk?
And you mentioned telehealth, DME, and we also see it with genetic testing, it continues to dominate enforcement. So, what are some specific compliance breakdowns triggers scrutiny here? How can firms distinguish legitimate growth from patterns that raise red flags?
Sure. So I think these sectors keep showing up in enforcement because they all share the same basic economic structure, which is they're very easy to scale, they are highly reimbursed, and can be distinguished from a more traditional doctor-patient relationship. And because their economic structure is so similar, I think the compliance breakdowns are also very similar. And I would categorize that into three buckets. The first is how the patient was found. So I think, if the patient was found from lead generators or call centers or online ads, that's risky. We know it is. Those are the exact fact patterns that I sort of came up on in law school. And so we know that that works historically for enforcement. And so the DOJ is going to continue looking at that and looking at whether patients were actually seeking this care or whether they were being steered into it. The second bucket that I would consider is what was the physician's role or the provider's role? So many of these cases will find that physicians function like claim validators more than actual clinicians. So they might never even speak to a patient. They might be paid per chart. They might be reviewing sort of hundreds of orders a day. And that, again, is a huge red flag because it suggests that their medical judgment is being commoditized rather than being used for medical necessity or to identify the patient's medical necessity. And then I would say the third bucket is what gets ordered. So if every patient ends up with the same genetic test, the same brace, the same wound care product, that suggests that there's something a little funny about that business model, right? It's more about utilization and not necessarily clinical need. So to that point, for your question about how do you tell sort of good growth from risky growth, I think legitimate growth looks messy, and you can see that, in any business, any small business. I come from a family of small business owners. Growth is messy. There are good days, there's bad days, you have ups and downs. And so you'd see the same thing for a healthcare provider. You'd see different diagnoses, different providers, variable treatment patterns, real genuine chart notes that might even lead to real disagreements about the best treatment path for a patient. But when it becomes fraudulent, it looks really clean, right? It looks like the same codes, the same orders, the same vendors over and over again, the same marketing funnels, the same prescriptions. And so because the DOJ can see so much data, when you see a system that produces sort of uniform outcomes at that high of a scale or volume, in any other industry, you might think efficiency, but in healthcare, we might think some of that is manufactured. So that's where you start to see a little bit of risk exposure.
Yeah, and you mentioned earlier how, the data is so voluminous. The data the DOJ and all these government auditors have access to so voluminous. And so as a statistician or economist, I deal with that all the time, and I've, analyze claims that are Roman data. And with the advent of AI and machine learning, you can kind of train these models to detect these kind of fraud patterns. So we've, if you look at a particular state or city or whatever kind of segmentation you want to look at, and you look at, the Medicare census, you look at utilization levels, or you look at year over year growth. And if you can, you can easily, the government has, trained these things to detect these outliers. So oftentimes, so it's very easy, it's become very easy with the amount of scale of data that we have access to.
Absolutely.
So in your article, you've discussed the pace of Medicare Advantage enrollments. So as Medicare Advantage enrollment grows, DOJ scrutiny of risk adjustment coding has intensified. How is this reshaping the link between reimbursements and liability, especially when using outside vendors to submit codes?
Sure. I think we talk about it very often, especially among the AHLA group, about how Medicare Advantage is just so fundamentally different from traditional fee-for-service Medicare. What matters in this context, however, is that in Medicare Advantage, you're not paid for what you do necessarily. You're paid for how sick your patients are, frankly. And so that makes coding the sort of engine of the Medicare Advantage program. And I think what the DOJ has identified is that many plans and provider groups have outsourced that piece to vendors. And so you might find chart review companies, home visit vendors. To your point now, there's AI coding platforms, offshore teams, whatever it may be. And those vendors are paid to find diagnoses, right? To make or find ways to make your patient look sicker, not necessarily to treat the patients. And so the legal risk there comes from the fact that under the False Claims Act, you own whatever gets submitted in your name, even if a third-party vendor generated it. So if you, for example, pay a vendor to search charts for revenue-enhancing diagnoses and you don't validate what they submit, well, you didn't just outsource that coding, you also submitted any false claims risk. And now that you didn't validate what they submitted, you still own it. And so when we think about using vendors, especially in the Medicare Advantage program, they're not just operational vendors at this point. They need to be considered regulatory extensions of yourself. And so you can't just say, we didn't know the codes were wrong, our vendor did it. The DOJ's view is, you found the vendor, you paid the vendor did the work that you asked them to do. You just didn't check their work, but you still kind of own the result.
Yeah, great. So in our own work, we've seen a pivot from whistleblowers-led investigations to FCA investigations that often are driven by data analytics. You mentioned this as a key trend in your article as well. So given that shift, what must a compliance program look like heading into, well, now that we're in 2026? And what is the single most important mindset shift leaders need to make?
Sure. So I think, at the beginning, we talked about what enforcement used to look like, what it looks like now. Similarly, compliance, I think, used to be built around reacting. So you get a hotline call, you figure out what's going on. You have a disgruntled employee, figure out what's going on. Maybe something goes wrong, and then you audit it. So it's very reactive. But like we talked about, the new enforcement model is just so data driven that it's based on, predictions, extrapolating, inferences, because you have so much data. So you can use those data analytics, the utilization trends, benchmarking, comparisons, you name it, all the things that you do as a statistician that I try to stay very far away from. But because it's so data focused, compliance has to evolve in the same way. And so a compliance program needs to be analyzing claim patterns and monitoring vendors and looking at their referral flows. But what they need to continue to do is view their data in the same way that the DOJ might, right? Put yourselves in the shoes of the DOJ and think, how would my data look if the DOJ were viewing it? And so it's not just about having a lawyer review your policies or your code of conduct and then putting it in a binder and sticking it on a shelf. It has to be more operational than that, right? You need a lot of those data analytics dashboards, anything that can detect anomalies, real-time audits, and most importantly, always for compliance, is that the compliance function has the authority to stop or change business practices that are a little risky. And so moving forward, I think the mindset shift is not necessarily is this technically allowed so much as what story does my data tell, right? Because we've talked about this. The DOJ, with all the data they have, they're looking at patterns. And so if your data or your patterns, if that story only makes sense because of some questionable tactics, that's a story that the DOJ maybe wants to hear and is going to tell a little differently than you would tell. And so I think the companies that do really well moving forward are the ones that will treat compliance as sort of an active, important part of their business function rather than just a reactive shield.
Yeah, I've definitely noticed of recent there's been an uptick in terms of when our services has been retained in a privileged consultant capacity, where the provider has, retained outside counsel, and outside counsel has brought us in privileged consultant capacity to kind of do to design a statistical sample, then have, medical reviewers to kind of review their claims and then see if there are any kind of exposure. And, sometimes you catch something, sometimes you don't. And that's conversations that the client in their outside counsel will have in terms of voluntary, recoupments or, self-disclosures and things of that nature. And I've also seen it in where like these private equity deals where they're buying hospital systems and they're buying physician groups, they just kind of want to know part of their due diligence, what's going on here, what's under the hood.
Mhm.
So rather than be reactive after the deal is closed, they want to be more proactive where they're actually looking at, some of these things that you mentioned earlier.
Yeah, absolutely. That makes sense. It's very interesting to hear about it from your perspective.
Yeah. Well, I mean, that's been a great conversation, Mega. It's been a pleasure to speak with you today, and I just want to thank you for taking the time for me and the listeners.
Great. Thank you so much.